اوكي ان شاء الله. بسم الله الرحمن الرحيم. النهارده معانا acute burn patients. Definition: a burn is an injury to the skin or other organic tissue primarily caused by heat or due to radiation, radioactivity, electricity, friction, or contact with chemicals. Epidemiology: it is estimated that there are between 7 and 12 million people each year, up to 33,000 each day, who sustain burn injuries that require medical care, according to the World Health Organization. Roughly 180,000 people die from a burn injury every year. Causes of acute burners: hot liquids or vapors, hot objects, electric currents and lightning, radiations such as sunlight and X-rays, chemicals, exposure to extreme cold. People at risk of burn: young children, older adults, people with disabilities, those in specific occupations or living situations. Classifications of burn injuries: burns can be classified according to their severity, depth, and size of the burn. Classification by depth: first degree, second degree constitute of superficial and deep burns, third degree, fourth degree. Classification by depth: superficial thickness or first degree burns are burns that affect the epidermis only and are characterized by redness, pain, dryness, and with no blisters, like sunburn. Partial thickness or second degree burns: these burns involve the epidermis and a portion of the dermis. Partial thickness burns are often broken down into two types: superficial partial thickness burns and deep partial thickness burns. Superficial partial thickness burns involve the epidermis and a part for the dermis layer of the skin. Superficial partial thickness burns extend through the epidermis down into the papillary or superficial layer of the dermis. The injured site become erythematous because the dermal tissue has become inflamed. When pressure is applied to the reddened area, the area will blanch, but will demonstrate rapid capillary refill upon release of the pressure. Deep partial thickness burns: these burns extend deeper into the dermis and cause damage to the hair follicle and the glandular tissue. They are painful to pressure, form blisters, are wet, waxy, or dry, and may appear ivory or pearly white. Full thickness or third degree burns: these burns extend through the full dermis and often affect the underlying subcutaneous tissue. Skin vary from waxy white to leathery gray to charred and black. The skin is dry and doesn't blanch to pressure, is not painful due to the damage of the nerve index. The dead skin eschar are removed in a surgical procedure known as escherotomy, which involves incising through sections of burned skin to release the eschar and its constrictive effects, such as distal ischemia, compartment syndrome, respiratory failure, tissue necrosis, or death. This is the lines of sclerotomy in different body parts. Subdermal or fourth degree burns: these involve injury to the deeper tissues, such as muscle or bone. They are often blackened and it frequently leads to loss of the burned part. This is the table of different types of skin burn according to depth and the appearance, capillary refill, sensation, pain, and healing periods. Classification by size: burn size is determined by one of three techniques: the rule of 9, the Land-Browder method, and the Palmer surface. The rule of 9. The rule of 9 is used to estimate the total body surface area involved in burn patients and also used to estimate fluid resuscitation required by a burn patient. The body surface estimation is by assigning percentages to different body areas like head, chest, abdomen, limbs. Upper limb is differ from lower limb and genitalia, and it differs between adult and children. Rule of palms: in pediatric palm, the whole palm, inter palmar surface, including the palmar and the digits, it estimates 1% instead of adult. The palmar surface is 0.5%, and the whole palmar surface includes the palmar surface of the digits include 0.8%. It is good for total body surface area less than 15%. This is a chart for Lambda Browder chart. Pathophysiology of burns, local effect and systemic response. Local effect, zone of coagulation. This occurs at the point of maximum damage, and this zone is characterized by irreversible tissue damage due to coagulation of the constituent proteins that occurs as a result of the insult. Zone of stasis or zone of ischemia. This zone lies adjacent to the zone of coagulation and is subjected to a moderate degree of damage associated with vascular leakage, elevated concentration of vasoconstrictors, and local inflammatory reactions resulting in compromised tissue perfusion. But the integrity of the tissue in this zone can be saved with proper wound care. Zone of hyperemia. This is the outermost zone. It is characterized by the eased blood supply and inflammatory vasodilatation. The tissue here will recover unless there is severe sepsis or prolonged hypoperfusion. And this chart demonstrates the difference between inadequate resuscitation and adequate resuscitation. Systemic response, once total body surface area is more than 30% burned, a systemic inflammatory response will occur. The renal and hepatic systems are susceptible to dysfunction due to the resultant fluid and protein loss and decreased blood volume. In major burns, the fluid state of the patient must be carefully managed. Adequate fluid resuscitation are crucial in curbing the extent of systemic dysfunction from this mechanism. Similarly, over resuscitation with excess fluid can have detrimental effects on cardiovascular, cardiorespiratory function and contribute to compartment syndrome. Widespread inflammatory response also occurs as the result of a burn injury with release of catecholamines, vasoactive mediators, and inflammatory markers, which can trigger a systemic inflammatory response syndrome, resulting in multiple organ dysfunction syndrome. Systemic response, like respiratory, may suffer from constriction, adult respiratory distress syndrome, and on the metabolic state, basal metabolic rate increased threefold. Immunologically, reduced immune response. Cardiovascular may reduce myocardial contractility, increase the capillary permeability, leading to edema, pulmonary edema, and on peripheral and splanchnic vasoconstriction. Management of acute burn. Assessment, history of burn, time of injury, mechanism of injury, including circumstances for specific pattern of burn. It's called estimate temperature and ask about the nature of the liquid. Contact, estimated temperature and the nature of the surface. Radiant, common causes include some burn. Friction, common causes include falling on or touching moving treadmills or road rash after a motor vehicle crash. Flame and explosion. Ask about the product that burned or exploded to predict temperature and predict secondary effects. Ask about the location where the patient was exposed. Indoor flame injuries are more likely associated with inhalation injury. Ask about the duration of exposure to predict the extent of burn. Common causes include flash burns after pouring accelerants like kerosene or petrol onto barbecues. Electrical, low voltage less than 1000 volt, typically domestic. High voltage more than 1000 volt, often industrial and lighting. Type of current, alternating current or direct current. Direct current typically provides a single convulsion or contraction, usually propelling person away from source, whereas alternating current causes repeated convulsions and cardiac arrhythmias, such as ventricular fibrillation, and is considered more dangerous. A larger magnitude of direct current is required to cause injury than alternating current. Was there a flash or arcing more likely to cover a larger surface area and be more superficial time and duration of contact to predict severity of burn? Common cause include young children chewing on electrical cords. Chemical, ask about the type of product to predict the extent of burn and secondary effects, alkali versus acid burns. Look at clothing for stain color, cold, direct contact with cold surface or exposure, frostbite. Inhalation, common causes include inhalation of hot gases during house fire or flame burns to the face, if occurred in enclosed space. First aid, time to start it. Was it within 3 hours? Agent used cool running water versus less effective agents like standing water, cold compressed ice, home remedies. Duration, was it at least 20 minutes of cool running water? If clothes and jewelry were removed, decontamination method for chemical exposure. Any circumstances to implicate coexisting non-burn injuries like fracture or wounds. Any circumstances to implicate non-accidental injuries or vulnerable child like homicide or abuse. Tetanus status. Assessment primary survey. Like all traumas, burn assessments require an initial primary survey with the aim of identifying and managing immediate life threats. Do not be distracted by the burn injury until all immediate life threats have been addressed. Do not neglect to apply personal protective equipment, which is especially important to protect healthcare workers where the patient has a chemical burn. Airway, examination of airway, signs of airway burn, inhalation injury, like stridor, hoarseness of voice, black sputum or respiratory distress, singed nasal hairs or facial swelling, sign of oropharyngeal burn, presence of soot on mouth, intraoral edema and erythema, significant neck burn. Management. If suspicion of airway burners, apply high flow oxygen. If above present, consider early intubation by an experienced airway specialist. Protect the cervical spine with cervical spine motion restriction if there is associated trauma. Breathing, examination of breathing. Signs of inhalation injury as above, full thickness and or circumferential chest burners, tension pneumothorax, secondary to an explosion associated trauma. Management, decompressed tension pneumothorax by thoracostomy and chest drain insertion. Full thickness or circumferential chest burners may require sclerotomy to permit chest expansion. Circulation examination. If early shock is present, consider causes other than the burn. For circumferential burns, check peripheral perfusion and the need for sclerotomy. Management. IV or intraosseous access, preferably 2 points of access. Consider IV fluid resuscitation. Resuscitative fluid management in burns more than 10%. This is required to compensate for excess fluid losses in the first 24 hours after burn. Calculate requirements from time of the burn, not time of presentation. Calculate fluid volume using modified Birkeland formula. Hartmann's solution is the fluid of choice. If unavailable, use normal saline. Glucose in maintenance fluid is required for children less than 20 kilograms. Modified Birkeland formula. It includes number one, A is the total burn surface area. You have to estimate total burn surface area and the weight of the patient. Time since burn. Volume fluid already received, if he received any volumes. And if time since burn is more than 7, do it 7 for result C. Step 1, calculate estimated fluid required in the first 24 hours from time of the burn injury. 3 is 3 ml fluid. Multiply for figure A, percent is the TIPSA or total burn surface area. Multiply by weight will lead to the result E. Adjust the volume to account for initial fluids already received. If he received any fluid, you have to deduct this amount. The result E minus the result D, the received fluid, will give the result F. Adjust the volume to account for initially maximal increased vascular permeability. The result F divided by 2, as we will give the half of the fluid in the first 8 hours, and the rest will be on the next 16 hours, will lead to the G result. Adjust the rate calculation to account for time elapsed since the burn injury. G is the maximal, the dose of fluid will be given in the first 8 hours. Is divided by the time of the burn. If 8 minus the C will give us the result H, ml per hour. Start IV resuscitation fluid at the rate of the result H, ml per hour. For the account of hours. The modified Birkeland formula is to be used as a guide only, and the patient's fluid state and urine output should be re-evaluated in 1 to 2 hours of commencing fluids and rate adjusted accordingly to target an optimal urine output of 1 ml per kg per hour. Sustained urine output less than 1 ml per kg per hour, increase fluid rate. Sustained urine output more than 1 ml per kg per hour, decreased fluid rate. Disability, neurological state, Glasgow coma scale, and pupillary response. If suspicion of carbon monoxide poisoning, apply high flow oxygen. Neurovascular status if limb involved. Assess with Doppler ultrasound if necessary. Requires elevation of the affected limb and hourly neurovascular observations. Exposure, fully expose the patient in order to assess the extent of injury in terms of the percentage of total burn surface area that is affected by the burn and the burn depth. Check the patient's temperature. It is easy to become hypothermic after cooling. The principle is to keep the patient warm, but the burn cool. Assessment of burn depths. Burns are dynamic wounds. It is difficult to accurately estimate the true depth and extent of the wound in the first 2 or 3 days. Burns are described as epidermal, dermal, superficial, mid-deep, and full thickness. Speed of capillary refill is a good indicator of burn depth. Also, burn wound evolution results in increasing depth, therefore examination can change over time. Most burn wounds are not homogeneous depths. This is a table for superficial and deep burns, and the characteristic color, blisters, if there is blisters, capillary refill sensation, like this. Consider alternate diagnosis. Scald burn mimics staphylococcal scalded skin syndrome, blistering distal dactylitis caused by group A streptococci, Stevens-Johnson syndrome, toxic epidermal necrolysis, follows medication used as flagyl or azithromycin. Hair tourniquet, distal erythema, and swelling can mimic peripheral burn. Burn wound management. Acute management of superficial burns with erythema only can be treated without dressing. Who show a tendency to blister or scratchy, a protective low adherent dressing with crepe bandage may be helpful. Acute management of minor burns, isolated or less than 10%, analgesia may be required for assessment and initial dressings. Consider sling and splinting. Dressings can be remain in situ for 3 to 7 days. The depth of a partial thickness burn may only be declared after 7 to 10 days because it is a dynamic process. D-roof or debride if blister is large or overlying a joint. Acute management of major burns, more than 10%, or complex burns. There is abbreviation FACAGE. First aid, analgesia, clean, assist, dress, elevate. First aid, remove jewelry and clothing in contact with burn sores. Do not remove. Bitumen is like tar stuck to a burn. Cool affected area as soon as possible. Prevent hypothermia. Cover burn with plastic sling film lengthways along the burn. Do not wrap circumferentially. Discuss chemical burn decontamination with poisons information. Appropriate consented photos of burns should accompany a referral of if possible. Analgesia. Burns are painful and often require strong analgesia. Appropriate initial choices include intranasal fentanyl or intravenous morphine. Analgesia is required especially during cooling, dressing, and mobilization. Like morphine sulfate, in adults, the dose is 0.1 to zero point 0.2 milligram per kg intravenous. In children, 0.1 to 0.2 milligram per kg per dose, intravenous or intraosseous. Other pain medications commonly used, Bethadine and non-steroidal drugs. Clean, limit debridement to wiping away clearly loosed blistered skin, remove blister with moist gauze or forceps and scissors if more than 5 millimeter or crossing joints. Clean burn wound and surrounding surface with saline or water or 0.1% aqueous chlorhexidine on gauze. Flannel if no gauze, like any clean texture. Assessment of burn injury by total burn surface area and depth. Take photos with appropriate consent. Dress. Apply appropriate occlusive non-adherent dressing. If these products are not available, refer to local burn service for alternative options. Elevate burn by positioning adjuncts like pillows, towels, slings. Elevation aids the management of edema to minimize poor tissue perfusion and improve wound healing. Do not apply tight circumferential bandages. Elastic compression is helpful. Encourage functional activity of affected body parts. Burn severity and the criteria for admission and transfer. There is minor, moderate, or severe burn. Minor burn, less than 10% burn in adult, less than 5% burn in young or old, less than 2% full thickness burn will be managed as outpatient. Moderate burn, like 10 to 20 percent burn in adult, 5 to 10% burn in young or old, 2 to 5% full thickness burn, high voltage energy, suspected inhalation injury, circumferential burn, concomitant medical problem predisposing the patient to infection like diabetes, sickle cell disease, will be hospital admission. Major burn, more than 20% burn in adult, more than 10% burn in young or old, more than 5 full thickness burn, high voltage burn, non-inhalation injury, any significant burn involving the face, eyes, ears, hands, feet, genitalia, or joints, significant associated injuries like fracture, other major trauma, will be referred to a burn center. Operative management. Superficial wounds should heal by regeneration within 2 weeks and need only cleaning, dressing, and review to optimize healing. If a burn has not healed within 2 weeks, it should be referred for assessment and may require surgery. Deep partial thickness or full thickness burns are likely to require operative management, which includes excision of the deep burn and skin grafting within 5 to 10 days to expedite healing and minimize scarring. Sometimes artificial dermis is used as a bridge to skin grafting. Skin grafts can be autografts or allografts. Grafting consists of 4 steps: the removal of injured tissue, selection of a donor site, an area from which healthy skin is removed and used as a cover for the cleaned burned area, harvesting, where the graft is removed from the donor site, placing and securing the skin graft over the surgically cleaned wound so it can heal, For large burns, multiple operations may be required to complete the grafting process. Investigations. Major burn more than or equal 10%, we will request hemoglobin, electrolytes, blood glucose level, blood group and hold, VPG. Suspected inhalation injury, we will request carboxyhemoglobin for carbon monoxide, toxicity, lactate, cyanide level. Electrical burn, cardiac monitoring, urine myoglobin. Special considerations. Circumferential deep burn, deep dermal or forest thickness, elevate part of limb distal to burn to minimize swelling and edema. Assess and monitor for neurovascular compromise of tissue distal to the burn, as carotony may be required. Limb burns elevates the limb and monitor perfusion distal to burn. Hand burn, hand burns are common. Special priority may be given to early activity rehabilitation to optimize hand function. Treadmill injury, a burn friction injuries from treadmills. Treadmills are commonly on children's hands and cause serious burns, often requiring surgical intervention and lengthy rehabilitation. Head and neck burns, head up to reduce swelling and edema. Ocular burns. Signs of ocular burns include blepharospasm, tearing, and conjunctivitis. All facial burns should have ophthalmological assessment, including visual acuity, external ocular exam, and fluorescein eye drops to assess for corneal damage. Both thermal and chemical corneal burns threaten vision. Alkalis penetrate deeper and have greater potential for serious and delayed burns. Treat all ocular chemical burns with copious irrigation using normal saline as soon as possible. Use topical anesthetic on affected eye for analgesia and to aid tolerance of irrigation. Irrigate until all chemical alkali washed out. Test with pH strip prior and post. Up to 1 hour with acidic contamination, up to 2 hours with alkali contamination. Use topical chloramphenicol to prevent secondary infection. Urgent ophthalmology review is required for all ocular burns, full thickness eyelid burns, facial burns with inability to close eyelids. Electrical injuries. Degree of injury is related to the voltage of the electrical source. Electrical injuries can be associated with other injuries. Consider spinal precautions. Electrical injuries can also cause cardiac dysrhythmias. Consider 24 hours ECG monitoring. Monitor and manage elevated CK, urine hemoglobin, myoglobin. Monitor for compartment syndrome. Electrical injury, labial artery erosion. This is important. Electrical burns occurring at the edge of the mouth can be associated with acute or delayed up to 21 days. Labial artery involvement and significant hemorrhage. Chemical burns. Acids cause coagulative necrosis of the superficial tissue. Bases causes liquefactive necrosis and have higher capacity for injury, including deep to the initial wound and ongoing injury process despite removal of base like laundry detergent. Organic solutions cause injury by dissolving the lipid membrane. Inorganic solutions cause injury by the tissue denaturation. First aid of chemical burns with irrigation of cool running water is extremely important and is often forgotten. Personal protective equipment for first aid givers should be worn. Gloves, mask, gown, eye protection. Ensure contaminated clothing is removed and brush any powdered agent of skin onto a collection sheet to be disposed of appropriately. Irrigate from the top of the wound down to the floor with appropriate drainage so contaminated water doesn't cause further injury. Causes systemic symptoms from metabolic and electrolyte disturbance from absorbed agent. Chemical burn, esophageal injury. Many harmful agents are found in households like toilet cleaner, bathroom cleaner, hair products, laundry and dishwasher detergents, batteries, and oven cleaners. Ingestion of caustic agent can lead to esophageal burns, strictures, and perforation. Injury may have symptoms include dysphagia, drooling, chest, abdominal pain, refusal to eat. Respiratory compromise, the injury tends to worsen over time. Tetanus-prone wounds, consider prophylaxis with vaccination or tetanus immunoglobulin is required. Inhalation injury. This occurs with flame burners in enclosed spaces. Direct inspection of the oropharynx should be performed on arrival and consideration of early intubation by an experienced airway specialist. Inhaled smoke is cool upon reaching the lungs, but products of combustion are irritating, leading to bronchospasm, inflammation, and swelling. This predisposes an individual to atelectasis and pneumonia and can be worse in asthmatics. Patients may require non-invasive positive pressure ventilation or invasive ventilation and airway toileting. Carbon monoxide and cyanide poisoning. If suspicion of associated carbon monoxide poisoning or cyanide poisoning, liaise early with burn unit, critical care and poisons information. Carbon monoxide is a toxic gas inhaled during a fire, such as patient includes in a house fire. Carbon monoxide binds very strongly to hemoglobin and intracellular proteins, contributing to intracellular and extracellular hypoxia. Toxicity is dose dependent, involving no or few symptoms through to cardiovascular compromise with seizures and death. Symptoms include gastrointestinal, like nausea, respiratory dyspnea, respiratory failure, cardiac system, syncope, cardiovascular compromise with myocardial ischemia, neurological dizziness, vertigo, ataxia, visual disturbances, headache, confusion, decreased conscious with seizures. Pulse oximetry cannot differentiate between hemoglobin and carboxyhemoglobin, so will not read low even when the patient is hypoxic. Blood gas will show metabolic acidosis and raise the carboxyhemoglobin. These patients require 100% oxygen or hyperbaric oxygen and may require ventilation. Unborn fetus can be affected by toxicity. Specific care of pregnant women with specialist teams. Levels of carbon monoxide from 0 to 5, normal value, from 15 to 20, headache, confusion, 20 to 40 will do disorientation, fatigue, nausea, visual changes, from 40 to 60, hallucinations, coma, shock state, and combativeness, like agitation. More than 60, mortality more than 50%. Remove a patient from source of exposure, administer 100% high flow oxygen. Half-life of carboxyhemoglobin in patients, breathing room air will be from 120 to 200 minutes. Breathing 100% oxygen will be about 30 minutes. Cyanide is a potentially lethal toxic poison that is produced in gaseous form from burning natural and synthetic fibers such as plastics and woods, such as in domestic industrial fires. Cyanide poisoning occurs from inhalation of this gas and often occurs with carbon monoxide poisoning. Toxicity is dose dependent and includes multi-system involvement, like gastrointestinal will do nausea, vomiting, respiratory will do tachypnea, dyspnea, cardiac will do tachycardia, hypertension, neurological headache, decreased consciousness state, seizures. More severe symptoms include end organ damage from anaerobic metabolism with associated hypotension, bradycardia, cardiovascular collapse, respiratory depression, and reduced Glasgow Coma scale. Blood gas will show metabolic acidosis with high lactate. Serum level cyanide should be taken. Treatment includes ABC resuscitation, high flow oxygen, and administration of antidote, hydroxycobalamin, then sodium thiosulfate. Frostbite. Frostbite is a type of burn injury to the skin and underlying tissue by freezing. It most commonly affects the extremities and can be divided into superficial or deep. It can occur through exposure to cold weather conditions or direct contact with cold ice, liquid, or metal. Minor frostbite injuries can be managed with simple first aid involving analgesia and rewarming, followed by simple wound care. More serious injuries may require review with the burners service for more intensive wound care management. Contraindications in acute burners. Several things are contraindicated to avoid further injury or complications. These include using ice or very cold water on the burn, applying greasy substances or ointments, and attempting to remove stuck on clothing or debris. Additionally, certain medications like succinylcholine should be avoided after the first 24 hours post-burn due to the risk of hyperkalemia. Post-acute care of burners. The type of care depends on the type, depth, and extent of burn. Burn dressings. The burn dressing will depend on the type and severity of the burn wound. Principles of burn wound management. Relieve pain, maintain a moist wound environment, keep wound clean, prevent or minimize infection. Staff and visitors must perform hand hygiene. Staff must wear gloves for dressing changes, and visitors who are unwell should not visit the patient. Nutrition. Positioning burn areas should be elevated to limit edema. Psychological care, rehabilitation, scar management, burn reconstruction. Post-acute care complications like itching, healing wounds are often itchy. Non-sedating antihistamines are safe option for symptomatic management. Edema, circumferential burns inhibit lymphatic drainage and venous return, resulting in edema, which may take 1 to 2 weeks to resolve. Elevation of the area will limit amount of edema and accelerate resolution of edema and minimize neurovascular compromise. Fever. Fever is a common reaction to hypermetabolic state and immune response following burn injury. Prophylactic antibiotics are not recommended in burns. If there is concern the burn wound is infected, send the swab and treat with empiric antibiotics as per local guidelines. Toxic shock syndrome is a rare complication of an infected burn and can be life-threatening. Signs and symptoms: shock, tachycardia, hypotension, fever more than 38.9 degrees, erythematous rash, diarrhea and vomiting, lethargy, irritability. Treatment includes active resuscitation with IV fluids, IV antibiotics, and urgent burns specialty care. Burn prevention. Prevention strategies should address the hazards for specific burn injuries, education for vulnerable population, and the training of communities in first aid. An effective burn prevention plan should be multi-sectorial and include broad efforts to improve awareness, develop and enforce effective policy, describe burden and identify risk factors, set research priorities with promotion of promising interventions, provide burn prevention programs, strengthens burn care, strengthen capacities to carry out all of the above. In addition, there are several specific recommendations for individuals, communities, and public health officials to reduce burn risk, includes fires and limit the height of open flames in domestic environments, promote safer cook stoves and less hazardous foils, and educate regarding loose clothing. Apply safety regulations to housing designs and materials and encourage home inspections. Improve the design of cook stoves, particularly with regard to stability and the prevention of access by children. Lower the temperature in hot water taps. Promote fire safety education and the use of smoke detectors, fire sprinklers, and fire escape systems in homes. Promote the introduction and of introduction of and compliance with industrial safety regulations and the use of fire retardant fabrics for children's sleep wear. Avoid smoking in bed and encourage the use of child-resistant lighters. This is the references, and thanks.